Porphyrias. Porphyrias are a rare group of metabolic disorders wherein there is excessive production of porphyrins, which are responsible for the clinical features. So it's a disease, it's a metabolic disorder characterized by increased amounts of porphyrins, which are responsible for the clinical features of the disease. We have cutaneous as well as neurovisceral manifestations present in the disease. King George III had variegate porphyria. That's of some importance here. This is the heme synthesis pathway. Here we have glycine and succinyl-CoA, which in the presence of ALA synthase form amino-levulinic acid. That amino-levulinic acid in the presence of ALA dehydratase forms porphobilinogen. That is acted upon by porphobilinogen deaminase to form hydroxymethylbilane. Hydroxymethylbilane spontaneously will form uroporphyrinogen 1, which is acted upon by the uroporphyrinogen decarboxylase to form coproporphyrinogen 1. The isoforms are important here, and the hydroxymethylbilane is acted upon by uroporphyrinogen 3 synthase to form uroporphyrinogen 3. Then there is uroporphyrinogen decarboxylase, which decarboxylates it to coproporphyrinogen 3. From uroporphyrinogen 3, there is coproporphyrinogen 3, which is formed, which is acted upon by coproporphyrinogen oxidase to form harderioporphyrinogen, which is acted upon by coproporphyrinogen oxidase to form protoporphyrinogen, which is acted upon by protoporphyrinogen oxidase to form again protoporphyrin 9, which is acted upon by furochelatase, and there is addition of iron to form our final product, which is heme. Various enzymes involved here can be deficient from various types of porphyrias, which we will study one by one. So these porphyrias can be either acute porphyrias, they can present acutely, or they can be only cutaneous porphyrias, and they can be mixed porphyrias with both acute and cutaneous manifestations can be present. Okay, so in the acute porphyrias we have acute intermittent porphyria, then we have plumboporphyria. Plumboporphyria is ALA dehydratase deficiency porphyria. Then we have porphyricutaneia tarda, which is the cutaneous form, which also includes 4 types, that is type 1, type 2, type 3, type 4. Type 1 is sporadic, type 2 and 3 are familial, and type 4 is toxic type. So that is one cutaneous porphyria. Second one being congenital erythropoietic porphyria. Then we have erythropoietic protoporphyria, erythropoietic coproporphyria, and hepatoerythropoietic porphyria. All of these are the cutaneous forms. Then you have the mixed form, which is the variegate porphyria and the hereditary coproporphyria, which is also called as harderioporphyria. So this is about the way in which we approach the case, whether it's acute, whether it's only cutaneous, or whether it's mixed. Firstly, coming to the congenital erythropoietic porphyria, it is also called as Gunther's disease. So congenital erythropoietic porphyria is also called as Gunther's disease. It is autosomal recessive condition. It is seen in infancy and childhood. Rarely it can be seen in adulthood also. There is mutation of this uroporphyrinogen 3 synthase here. This is the enzyme deficient here, and which causes the porphyria, that is congenital erythropoietic porphyria. Biochemical abnormality will be uroporphyrinogen 3 synthase deficiency, and there is because there is deficiency of uroporphyrinogen 3 synthase, there will be increase in the 1 isomer here. The spontaneous formation from the hydroxymethylbilane, uroporphyrinogen 3 synthase won't act on it. It will spontaneously be formed into uroporphyrinogen 1, and then later which will be converted into coproporphyrinogen 1. The isomer will change, which accumulates in the bone marrow, the red blood cells, in the plasma, bone and teeth. Urine and feces also, there is presence of this porphyrins which are seen. Clinically, we see in utero it can present with non-human hydrops fetalis, and the patient can present severe hemolytic anemia. Sometimes even the mother complains of the staining of the diapers, which can be the first clue. Burgundy red urine or red staining of diaper can be seen, which is one of the main indications of the disease here. Also, there can be meconium staining can be present. Neonatal jaundice can be seen, phototherapy, and which can cause severe reaction here. Okay, mutilating photosensitivity again is an important finding here, and hypertrichosis erythrodontia, which is colored teeth, red colored teeth, can also be present in this condition. There will be itching present, erythema, which leads to painful vesiculobullous lesions, later which forms crust and pigmented scars. There is severe mutilation. After all of these crusts and vesicles they form severe mutilation of the fingertips, ears and nose. Coarse hair can be present on the face, and lanugo hair on the limbs. So the face will have coarse thick hair and the lanugo hairs will be present on the limbs, and this is called as a werewolf appearance, which is characteristic of this congenital erythropoietic porphyria. Sclerodactyly and nail dystrophy can be present because of the loss of terminal phalanges, and photophobia, ulcers, ectropion, scars, cataract, all of these will finally lead to blindness. Erythrodontia, that is colored teeth, pigmentation of bones, which is seen because of the uroporphyrinogen 1, the isomer which is deposited. Both deciduous and permanent teeth will show pink fluorescence under the Woods lamp examination. That is again important. Woods lamp examination will show pink fluorescence of the teeth, both the permanent as well as the deciduous teeth. And hepatosplenomegaly also can be present along with this. So this here we see the picture of the boy with congenital erythropoietic porphyria with crusted ulcers and hyperpigmented scars on the face. Here we can see the erythrodontia here. This is the Woods lamp examination showing pink fluorescence of the teeth. And these are the mutilating photosensitivity of the skin. Lab findings, here we find in histopathology that there is subepidermal blister formation with mild inflammation and thickened collagen leading to scarring will be present. Urine, feces and RBC, all of them will show increased porphyrin 1, uroporphyrin 1 and copperporphyrin 1. And stable fluorescence of erythrocytes can be seen. Prenatal diagnosis can be done using uroporphyrinogen 1 estimation in the amniotic fluid. Again, an important thing to be noted here. Next, coming to erythropoietic protoporphyria. This is the most common porphyria which is seen in children. So children will have this erythropoietic protoporphyria, and it is of early onset, autosomal dominant. Congenital erythropoietic was autosomal recessive. This is autosomal dominant, which is also second most common porphyria after PCT. PCT is the most common cutaneous porphyria. After that we have erythropoietic protoporphyria, which is the second most common. And here we have ferrochelatase mutation. The enzyme, the last enzyme in the heme synthesis will be mutated here. Biochemical abnormality, ferrochelatase is reduced here, leading to increase in protoporphyrin 9. Clinical features, it starts at 2 to 3 years of life and improves with age. As the patient ages, the disease improves. Photosensitivity may be the only cutaneous symptom present here. It presents with intense itching, pricking, burning sensation even after 5 to 10 for 30 minutes of sun exposure. Here, there's an important history that the patient gives you. Parents give history of children crying without any reason. That can be the history, and it can present with painful photodermatosis without any blistering also. Here we see that there is erythematous, edematous, petechial, purpureal, eczematous lesions are seen on the exposed sites. Small vesicles, photoonycholysis can be seen. Superficial linear circular scars can be seen. Deep wrinkles are seen, usually in the nasolabial fold and lower eyelids and lips. So on the face, deep wrinkles can be seen. Periocular subnasal area is spared. So because they are protected from the sun exposure, so the periocular area, subnasal area will usually be spared here. And there will be thickened waxy scarring of the skin, which gives a premature aged skin appearance. Spectral sensitivity seen at 400 nanometer. Excellent life expectancy they have, associated with cholecystitis, cholelithiasis, and hepatic cirrhosis can be also present. So these are the superficial scars on the face in a patient. This is the edematous hand initially presenting like this. Differential diagnosis can be polymorphic light eruption, hydrovacciniform, and hydroastival solar urticaria. Lab findings in this will be, there will be marked dermal eosinophilic homogenization is seen. Thickened blood vessels with PS positive material. IgG deposits can be seen on immunofluorescence. Both the erythrocytes, plasma, feces will show increased free protoporphyrin levels because ferrochelatase is deficient here. There is no conversion of protoporphyrin to heme. RBCs and VCs will show copperporphyrins, and they give a coral red immunofluorescence. Fluorescence will be coral red fluorescence in Woods lamp. And urinary porphyrins will be normal here, but protoporphyrins, because here in this condition protoporphyrins are increased in amount, right? So these protoporphyrins are insoluble in water, therefore in urine you can't see, but in feces and RBCs you can see. Vitamin D levels will be decreased because of decreased sun exposure. You tell the patients to reduce sun exposure, that will cause decrease in vitamin D levels also. Next, coming to erythropoietic copperporphyria. It's a very rare condition. Localized edema following sun exposure is seen only on sun exposed areas. And RBCs, if you see, there will be increase in copperporphyrins, uroporphyrins, and protoporphyrins. Urine and stool will be normal in amount of porphyrins. Next is porphyric cutaneous tarda, which is the most common form of the porphyria. There will be no well-defined pattern of inheritance here. We have type 1, 2, 3 and 4 types of PCT. Type 1 is the familial, is the sporadic form of porphyria. Type 2 and type 3 are familial forms. Type 4 is the toxic form of the porphyria. The triggers for PCT development would be, the important triggers here are alcohol intake, estrogen, glycofulvin, hydrantoin and hepatic. So these are the some of the triggers which can cause PCT. Type 4 is caused by chemicals like hexachlorobenzene and chlorinated hydrocarbons. And sometimes porphyric urinuria can be associated with HCV infections also. Biochemical abnormality in PCT, there will be decreased uroporphyrinogen decarboxylase enzyme deficiency here, okay? It can be either acquired or inherited deficiency. In type 1 type of PCT, only liver is affected. In type 2, all the tissues are affected. Type 3, there can be family history of PCT being present. Type 4 is a toxic type. Clinical features in type 1, it can be either acquired or sporadic. In adults, mostly it is seen. Type 2, childhood type. Cutaneous lesions here are in sun exposed sites on doors of hands, forearms, and face will be involved. There will be skin fragility, pigmentation, hypertrichosis, bullous lesions because of photosensitivity. And on intake of hard like liquor or sun exposure, bullous lesions can be seen. In the quiescent stage, the lesions heal with scarring, hypopigmentation, or milia. So when all of these pigmentation, fragility, bullous lesions heal, they leave a scar, or they can be hypopigmentation, or they can be milia formation. Also, changes of pseudoscleroderma changes can be seen. Hypertrichosis of the cheeks, the temples can be hypertrichosis can be seen on temples and eyebrows also. So monkey-like faces is seen here. Werewolf was seen in congenital erythropoetic porphyria. Monkey-like faces is seen in PCT. Children will have sclerodermal changes and dystrophic calcification. Conjunctivitis, photophobia, excessive tearing can be the eye changes. Systemic features would be diarrhea or constipation, insomnia, and anorexia can be seen. Monochromatic photobiological test will show spectral sensitivity at 400 nanometer here. Impaired LFT can be present. Iron overload will cause increase in serum iron levels in hepatic cirrhosis. Liver biopsy, if you do, it will show fatty infiltration, inflammation, necrosis, portal fibrosis, sometimes hepatocellular carcinoma also. So this PCT can be associated with diabetes mellitus, SLE, chronic renal failure, and also HIV infection can be associated with PCT. These are the hypopigmented lesions on the exposed sites here in the adult patient. Also again here on the dorsal of the hand you can see some exposed sites. There is another variant called as BANTU porphyria. Here porphyric urinuria is seen in Bantus of South Africa and Zimbabwe. It is due to a hepatotoxic effect of adulterated drinks which are brewed locally. In southeast Turkey we see PCT after accidental consumption of wheat which was dressed with hexachlorobenzene. So this causes the toxic form of the PCT. Toxic PCT is caused by hexachlorobenzene. Okay. Differential diagnosis of PCT would be variegate porphyria, epidermolysis bullosa because of the bullous lesions, hydrovacciniform, hydroastival, unexposed sites are involved. Certain drugs can cause photosensitivity. PMLE, scleroderma because pseudoscleroderma like changes are seen even in PCT. Lab findings would be in histopathology, subepidermal blister is seen if bullous lesions are present, minimum inflammatory infiltrate, papillary capillaries have PAS positive material. DIF, direct immunofluorescence will show IgG, C3 and IgM deposits around the dermal capillary walls. Urine will show dark brown red fluorescence under Wood's light here, okay. Porphyrin levels are, porphyrin profile is done here. There's a partial defect in uroporphyrinogen decarboxylase enzyme, right? So there is no conversion of uroporphyrinogen 3 to copper porphyrinogen 3 here. Uroporphyrinogen is water soluble, so it is seen in urine as well. Normal porphyrin is less than 250 microgram per 24 hours is the normal levels of porphyrin, that is increased here. Copper porphyrins are seen in urine and feces here. Isocopper porphyrin 3 in feces is seen. And RBC porphyrin profile will be normal. Next coming to acute form, which is acute intermittent porphyria. It is the most common and the most severe acute porphyria. Autosomal dominant here. All regions, all races are affected. Kumars of Bikaner district in western Rajasthan was seen. Chromosome 11 is involved here with mutation in porphobilinogen deaminase. This converts porphobilinogen to hydroxymethylbilin. That is affected here. 22 to 40 years age group is seen. Females are more commonly affected. Biochemical abnormality is deficiency of porphobilinogen deaminase. Clinical features, here we see hyperpigmentation, persistent vomiting and colicky abdominal pain. So there will be acute presentation here with persistent vomiting and colicky abdominal pain, vomiting or constipation, diarrhea, epilepsy, mental depression, autonomic neuropathy can be present. Precipitating factors for the acute attacks are severe fasting, severe starvation, dieting, emotional physical exhaustion, or acute any illness if it is there, febrile illness, menstrual cycle, pregnancy. Most important is the starvation and fasting, which can precipitate the attack. Certain drugs like we have barbiturates, sulfonamides, glycofulvin, chloroquine, oral contraceptive pills, alcohol again is important, anticonvulsants, antidepressants, which can trigger the acute intermittent porphyria. Differential diagnosis would be any other condition causing acute abdomen, any organic, neurological or psychiatric disease if the patient has. Hysteria has to be ruled out, lead poisoning has to be ruled out, paroxysmal nocturnal hemoglobinuria. Lab findings is HPE will be unremarkable, it will be normal. There will be foci of demyelination in the somatic nervous system and the autonomic nervous system. Axonal degeneration of the peripheral nerves can be seen. Centrilobular necrosis of the liver can be seen here. And acute attacks, urine on standing, it will turn dark due to the conversion of porphobilinogen to uroporphyrin and porphobilin. So that is again an important finding here. Next, coming to plumboporphyria. It's also called as ALA dehydratase deficiency porphyria because the enzyme is deficient here. Extremely rare condition and autosomal recessive, and clinical features are similar to acute intermittent porphyria, and chromosome 9q34 is affected here. Next, coming to variegate porphyria. It's a hereditary form of hepatic porphyria, autosomal dominant again. Protoporphyrin oxidase is mutated here. Chromosome 1q22 is affected here. Okay, it presents in 60% cases with cutaneous lesions and in 40% cases with neurovisceral symptoms will be present here. Biochemical abnormalities, protoporphyrin oxidase is deficient. Ferrochelatase also is reduced in 50% of the cases. Clinical features, we see photocutaneous, that is photosensitivity will be present, abdominal features and neural features will be present. Family history will be present in latent porphyria. There will be fragile skin which easily abrades with trauma. Blisters are seen on sunlight exposure. Onset before infancy, if it is present, they will present mutilating photosensitivity, nystagmus, seizures and mental retardation. No acute attacks are seen before puberty. So these are the lesions on the face, hypertrichosis and the healed post-inflammatory hypopigmentation. These are the lesions and blisters can be seen on sun-exposed sites. Precipitation is caused by illness, infection, barbiturate, sulfonamide, glycofulvin, analgesic sedatives, estrogens. So all of these are common for the other porphyrias as well. Lab findings, increase in urinary ALA and porphobilinogen levels. Port wine staining of the urine again is important finding here, okay, and exposure to sunlight. In between the attacks, it will be normal. Stool will show increase in protoporphyrins and coproporphyrins. Next, coming to hereditary coproporphyria. It's a very rare condition, autosomal dominant. Chromosome 3q12 is involved. Deficiency of coproporphyrinogen oxidase is seen here. There will be increase in coproporphyrinogen 3 levels in urine and feces. ALA synthase also has increased. CNS symptoms are less here. Clinical pictures like in acute intermittent porphyria or variegate porphyria, 80% cases will present with abdominal pain. Okay, that is the most distressing complaint that the patient will have. And photosensitive bullous lesions can be seen on the exposed sites. It's a mild disease. Hepatoerythropoetic porphyria. Here it's a rare disease, autosomal recessive, and early childhood it is seen, dark urine, marked photosensitivity, hypertrichosis, scleroderma lectins are seen even here. Biochemical abnormality, there will be deficiency of erythrocyte, uroporphyrinogen, decarboxylase, increase in protoporphyrin, urine will show uroporphyrinogen, feces will show coproporphyrinogen. Pseudoporphyria is a term wherein there is cutaneous lesions same like porphyria, but without any porphyrin abnormal metabolism won't be there. So there is no abnormality in the metabolism of porphyrins, but there is lesions which are seen like porphyrin, which resemble PCP. It can be because of certain drugs can cause this, and hemodialysis can cause pseudoporphyria, and sunbedding can cause pseudoporphyria. So the lesions are like PCT, but there is no abnormal porphyrin metabolism. Then there's dual porphyria where there can be association of one or more porphyrias. They can coexist. Management of porphyrias, urine and feces testing needs to be done for diagnosis. And it's an important test here. 10 drops of glacial acetic acid is mixed with 1 ml of amyl alcohol in 4 ml of urine. And you have to shake it well and examine under oat lamp. That will give you pink or red fluorescence. Okay, that's an important test to be done here. There's also false positive cases seen in lead poisoning, liver disease, infections, anemia, chemical intoxication with carbon tetrachloride. Screening of urine, stool, and blood porphyrins level has to be done. Fluorescence microscopy, spectrophlorometry is another investigation. In general measures, we have to avoid the precipitating factors. We have to carry a card which says that the patient has porphyria and what drugs need to be avoided, what drugs can be given, has to be written there. Alcohol sun exposure needs to be avoided, very important. Second being screening of the families needs to be done. Relatives of all patients with hereditary porphyria should be checked for porphyrins in urine, feces, and plasma. Warn latent porphyria subjects of dangers of barbiturates and alcohol. They also need to avoid barbiturates and alcohol. Then we have to avoid barbiturates, sulfonamides, cryophyllmin, anticonvulsants, antidepressants, meprobamate, ergot, methyl-dopa, ceormate. All of these can trigger the disease. That has to be avoided here. Management of active disease, if protection from sunlight is important. It is very important in the management of porphyrias because that is the main trigger factor. Clothing acts as a barrier. Night work would be preferred better than day work. Broad spectrum sunscreens which contains benzophenone, ibobenzone, clinosop needs to be given. Physical sunscreens with titanium oxide, zinc oxides also are important here. Beta carotene, that is oral sunscreen, which is of 60 to 180 mg per day. Beta carotene, which is an oral sunscreen, can be given here. Facial hair, if it is present, epilation needs to be done for that. For infected lesions, antibiotics are given. For CNS symptoms, paracetamol, aspirin, dihydrocodeine can be given. Promazine, chlorpromazine can be given for pain, emesis, and psychosis. Hypertension and tachycardia, we give beta blockers. For constipation, laxatives is enough. For obstipation, neostigmine can be given. For the convulsion, IV paraldehyde can be given. Fluid electrolyte balance needs to be maintained. Blood volume needs to be maintained. Correction of hyponatremia is done with hypertonic saline. High carbohydrate intake with 1500 to 2000 kilocalories per day is given. Infusion of hematin is required because it inhibits the synthesis. ALA synthase enzyme is inhibited by the hematin, so that can be given here. And blood transfusion is given in congenital cases. Venesection for removing the blood is given. Around 500 ml of blood is removed per week. Either once or twice weekly we can remove 500 ml of blood when a section can be performed. Plasma exchange, iron chelating agents like desferrioxamine, high dose vitamin E, liver transplantation is the end treatment, and alpha MSH analog like afamelanotide can also be tried in the treatment of the porphyria. Surgical procedures like splenectomy, bone marrow transplantation, hematopoietic stem cell transplantation, cholecystectomy if there is cholelithiasis, liver transplantation. Gene therapy is the hope for the future.